Good morning. I'd like to call this hearing to order. Today is Thursday, October 5th, 2023. The time is 10 a.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today, we will consider the Mayor's nomination of Dr. Ayanna Bennett to serve as the Director of the DC Department of Health, or DC Health. Dr. Bennett has been serving as the acting director since July of 2023, replacing interim director Dr. Sharon Lewis, who had served in that role since Dr. LaQuandra Nesbitt left the position in July of 2022. Dr. Bennett is a pediatrician with over 20 years of clinical and public health experience. She earned her MD and completed her pediatric residency at UC San Francisco Medical School and earned a master's in health and medical sciences from UC Berkeley School of Public Health through a unique program for doctors in training focused on health equity. From 2007 to 2016, Dr. Bennett was practicing as a pediatrician, including founding and leading the 3rd Street Youth Center and Clinic in San Francisco. In 2016, Dr. Bennett joined the San Francisco Department of Health as the Director of Interdivisional Initiatives, where she focused on long-term population-based initiatives like the Black African Health Initiative, which sought to address the health disparities of San Francisco's African-American residents. In 2019, Dr. Bennett became the director of the Office of Health Equity for the San Francisco Department of Public Health, creating anti-racism agency goals, policy improvements, and training to reduce interpersonal bias. She also co-led the COVID Emergency Operations Center for the city and the county of San Francisco, overseeing 600 employees and a $460 million budget, resulting in the lowest case and death rate among major cities nationwide. As the director of DC Health, Dr. Bennett would oversee almost 750 FTEs and lead the district's efforts to protect and enhance public health across a broad range of factors, including chronic disease prevention and treatment, maternal and infant health, infectious disease surveillance and immunization, health emergency preparedness and response, and the HIV and AIDS prevention and treatment. Dr. Bennett would also oversee the regulatory oversight and licensing for healthcare professionals, healthcare facilities, food and safety inspections, animal control, and health and hygiene inspections of businesses across the District of Columbia. I am especially thrilled that Dr. Bennett would bring her deep knowledge and expertise on health equity to the role. When I first met with Dr. Bennett in August, she shared her vision of outcomes-driven work on health equity, moving beyond process towards action. I look forward to a robust discussion with her about her vision and plans for DC Health at today's roundtable. I know that I will have some colleagues who will be joining. There is another hearing going on in the Committee on Judiciary and Public Safety this morning regarding the Office of Unified Communications. So there is going to be some folks who are going back and forth. Until they arrive, I'm going to go ahead and turn to our public witnesses. After that, we'll hear testimony from Dr. Bennett, and then we'll have a discussion where my colleagues and I will be able to ask her more questions about her expertise and experience. Before starting, I want to review our testimony guidelines for our public witnesses. Witnesses representing organizations will have 5 minutes to speak, and witnesses testifying on their own will have 3 minutes. Please be conscientious of your time, and we'll give you a nudge when your time has expired to preserve sufficient time for all public witnesses to speak today. I'm going to do, we have 10 public witnesses who have signed up, so I'm going to do 2 panels of 5. For those who are just joining us, or this is your first hybrid hearing with the council, you will need to affirmatively accept our invitation to become a panelist. So the first 5, Brenda Lee Richardson, coordinator of Anacostia Parks and Community Collaborative, Vanessa Batters Thompson, who's the executive director of DC Appleseed, Sal Salvago, who is part of the DC Coalition of Long-Term Care, Neil Richardson, and Takia Dalton. Give them a minute to come into the room. For those, this is a hybrid hearing. So I'm in room 412 of the John A. Wilson building, but our public witnesses will be testifying virtually. Okay. Well, we'll get started. I see Ms. Richardson. Why don't you go ahead?
Thank you, Chairman Henderson, it's great to see you again. My name is Brenda Lee Richardson. I'm a Ward 8 resident and coordinator of the Anacostia Parks and Community Collaborative, a network of residents and organizations who come together to improve and celebrate the Anacostia River and its park system. I am here today to enthusiastically support the confirmation of Dr. Bennett as Director of the Department of Health. We have a health crisis east of the river. Too many people living their worst experiences as it relates to health outcomes and more barriers to quality health care compared to other district residents. There are higher rates of breast cancer, infant mortality, and children with asthma, and limited resources to help people with mental illness. You already know the average life expectancy in Ward 7 and 8 are the lowest, but some estimates put the difference at more than a decade less than other district residents living just west of the Anacostia River. Even before the pandemic pulled many of our neighbors into a sedentary lifestyle and unable to work, poor health and widespread environmental hazards contribute to the additional burdens piled on top of the collective trauma we already experience every day. It's not a coincidence that neighborhoods with the most pollution in the air are the places with the highest levels of asthma, respiratory illness, and stroke. APAC and our allies are committing to helping reduce the growing disparity in health outcomes, and our goal is to take a more proactive approach to disease prevention at the grassroots level. This includes partnering with the district's leaders, like Dr. Bennett, to address urgent community needs by increasing resources and staffing at traditional healthcare providers, and also finding innovative ways to reduce the incidence of chronic illness through environmental intervention, including connecting more residents east of the river with nature and outdoor activities as a form of public health intervention. APAC strongly supports the nature-based trauma-informed programming in parks and green spaces, like the ones implemented at the national and local parks through community groups like the Friends of Oxen Run Park and the Friends of Anacostia Park. We know that having access to nature has the power to promote physical and mental health resiliency in the face of trauma and climate change. We now need to act on that knowledge by supporting park improvements to the Anacostia Park system and finishing the job. On the climate change front, we would like to see the Department of Health work closer with disfavored communities on issues like heat sensitivity, as well as indoor and outdoor air quality, which exacerbate our escalating health disparities. When people are suffering through the summer heat waves without air conditioning in their homes, that is a major problem for people with respiratory and cardiac conditions. We urgently need more health representation on the ground at the community level, monitoring and evaluating how environmental conditions adversely impact the overall health and well-being of residents. Other nature prescription programs like Green Spaces for DC's Park X show evidence of cardio and mental health benefits and should become more widespread. Giving patients prescriptions with specific goals of walking in the Marvin Gaye Park or biking at Kingman Island is a cost-effective supplement to conventional medical services that can help change the paradigm of disease and reduce stress. I would like to conclude my remarks today by saying the intersection between health, recreation, and the environment is clear. It is now time to shower the east of the river community with favor by taking action to prevent illness and death from avoidable conditions among our most vulnerable residents. I look forward to Dr. Bennett being a trailblazer as it relates to community health and climate change, and APAC stands ready to support her. And Chairman Henderson, I would like to say that we look forward to perhaps having a roundtable discussion at APAC with you and Dr. Bennett to learn more about your vision of dealing with the intersection of health and environmental justice. Thank you very much.
Thank you, Ms. Richardson, and I think we can certainly make that happen.
Thank you.
Vanessa?
Good morning, Councilmember Henderson. Thank you for the opportunity to testify regarding the confirmation of Dr. Ayanna Bennett as Director of DC Health. My name is Vanessa Batters Thompson, and I'm the Executive Director of the DC Appleseed Center for Law and Justice. DC Appleseed is a nonprofit, nonpartisan organization that aims to make the district a better place to live and work through litigation, teamwork, and advocacy. The HIV epidemic has long been a focus of DC Appleseed. For more than 20 years, DC Appleseed has worked closely with the DC government, including DC Health's HIV/AIDS, Hepatitis, STD, and TB Administration, HOSTA, to address the HIV epidemic in the district. I'm here today to support Dr. Bennett's confirmation to this role. Today, we remain concerned about health equity and the disparities we see in education, testing, and effective treatment of HIV. We hope Dr. Bennett's vast and varied experience will inform her work and allow her to successfully lead DC Health towards addressing these disparities in DC. In 2020, DC Health adopted a 95-95-95 plan to end HIV in the district. Unfortunately, the district is not currently on track to reach 2 out of 3 of the goals by 2030. Additionally, HIV affects some district communities more than others. Specifically, HIV disproportionately impacts our Black, Latino, and LGBTQ communities. DC also struggles to get young adults with HIV into treatment. To reach its 95-95-95 goal, DC will need to double down on its outreach and services to communities of color, the LGBTQ community, and youth. DC Appleseed is heartened by Dr. Bennett's extensive health equity background and experience working with marginalized populations and youth. We hope Dr. Bennett's background, including her background as a pediatrician, will inform this vital work, and that DC Health will recommit to increased and culturally competent outreach to these populations. A strong first step would be ensuring all DC public schools, public charter schools, and participating private schools offer STI and HIV education as required by the Healthy Schools Act of 2018. In prior conversations with DC Appleseed, community HIV providers reported difficulties maintaining a dialogue and exchanging ideas with DC Health and HOSTA. Addressing the district's health and health equity issues will require open and continuing communication with providers, especially those serving historically disfavored communities. Given Dr. Bennett's extensive clinical background, we have confidence that she understands that DC Health will need to work side by side with providers to successfully address current and emerging health issues in the district. As Dr. Bennett is surely aware from her time in the San Francisco COVID Command Center, effective communication must include timely and robust data sharing. DC Appleseed urges DC Health to publish citywide HIV data more routinely and promptly to ensure providers and advocates can adequately respond and adjust to health issues in real time. In recent years, it has taken HOSTA more than a year to publish relevant HIV data, although providers must report all suspected or confirmed cases within 48 hours through an online portal. We've seen that DC Health can provide real-time data under certain circumstances, for example, COVID and gunshot data. We asked Dr. Bennett to commit to making it a priority to distribute data more quickly and request that HIV data be released at a minimum monthly. Finally, nationwide data shows that public health workers are experiencing widespread burnout. Since the COVID pandemic, DC Health struggled with high turnover and many staffing vacancies. The next DC Health director will need a plan to recruit qualified individuals to fill those vacancies, while also focusing on the retention of current staff. Dr. Bennett has extensive leadership experience managing large staffs and budgets in various positions and settings. We are hopeful this experience will translate into a robust recruitment and retention plan for DC Health that will ensure the agency can fulfill its mission in the district. Thank you for your time. I will happily answer any questions regarding my testimony and health equity matters that the Director of the Department of Health must address. We look forward to working with Dr. Bennett.
Thank you. Sal?
Good morning. Good morning, Chairwoman Henderson. My name is Sal Salvaggio. and I'm representing Northwest Neighbors Village, the Ayanna Senior Services Advisory Group, and the DC Coalition on Long-Term Care. We welcome Dr. Bennett as Director of DC Health. I've testified before you previously on the topic of our insufficient healthcare workforce. My testimony today is meant to return to the importance of addressing that situation and to suggest to Dr. Bennett the possible role her department may have in coordinating actions to help. Before my retirement as a dentist, I saw in my patients the challenges that caring for an aging parent presented. I witnessed firsthand how having a trained healthcare aide to assist in the care of that parent made a difference in the welfare for both parent and child. I also experienced the importance of having these aides when my parents and my wife's parents required caregiving. We are all well aware of the challenges we have now and will continue to have in caring for our older community members. However, I'd like to emphasize that the shortage of healthcare workers will not only affect our aging population, but will have downstream consequences for our entire community, regardless of age. Let me present a few scenarios that are now occurring and will occur with increasing frequency. You may need to be admitted to a hospital for an urgent procedure. However, you are told that your procedure will need to be delayed until a hospital bed becomes available. A number of potential beds are being occupied by patients who can't be released because they require professional post-hospital home care. And even though home care agencies have been contacted, no one is available. Or you've had an accident and you're receiving care in a rehab facility. You find that you need help getting to the bathroom or take your medications. However, no one is answering your call button. The facility is short-staffed and everyone is too busy to help because you're helping someone else. They'll get to you when they can. Or you're taking care of an elderly parent in your home the best you can, but you have a job and a family. You need a healthcare aide to work in your home so you can make a living and at the same time keep your beloved parents safe and comfortable. Finding a steady available aide is difficult because of the high turnover rate that plagues the workforce. The district government needs to coalesce the many stakeholders to find pathways to solve the healthcare aide worker shortage. By creating one body to oversee and manage the effort, realistic solutions must and can be achieved. DC Health, under the leadership of Dr. Bennett, should explore the feasibility to be that body to bring together the many governmental agencies and regulatory entities who need to work together. The mayor's recent healthcare work task force provided a deep dive into the workforce situation and made a number of recommendations that could be instituted. The DC Coalition of Long-Term Care has previously sent to Dr. Bennett some recommendations regarding those regulations and other information that can help eliminate barriers to progress. And we stand ready to work with you and DC Health to find solutions. Being a healthcare worker is hard emotionally and physically. They care for us when we are most vulnerable. We ask from them their compassion and their competence. For the welfare of these workers and of our entire DC community, Dr. Bennett, we ask you to consider the proposals we recommended. And thank you for the opportunity to provide testimony. And I also am ready to answer any questions you may have.
Thank you, Sal. Neil?
Good morning. Good morning, Councilmember Henderson. My name is Neil Richardson. I'm Deputy Director at DC Appleseed. I'm going to testify on another issue that's different from Vanessa Batters-Thompson, who's my Executive Director at DC Appleseed. DC Appleseed worked to improve the district for a long time in a variety of ways, but one of the most important issues we've been working on is around long-term care issues and the way that we value our home health aides and CNAs and other direct service workers. We believe that this is an equity issue, and we are very pleased that Dr. Bennett has the experience that she does and that she had in San Francisco and California, serving those communities. Long-term care services affect the poor far more than the wealthy. You can afford private pay options. There's consistent and quality care should be provided to all, no matter where they live, what they look like, or their income status. Lastly, strong leadership is needed to re-energize the Board of Nursing that seems to us to be fatigued, understaffed, and secretive. So we've got a couple of recommendations. We want to improve the wages and job quality for direct service care workers. We'd like to advocate for more resources for training and education providers to address retention challenges and chronic staffing shortages. And we'd like to reinvigorate the Board of Nursing to approve medication aid programs, which we have a lot of difficulty getting information from the board about. So here are some ideas. Amend the Living Wage Act to establish a real living minimum wage of $24 an hour and ensure that it rises with inflation for all direct care workers who assist seniors or people with disabilities in the district. We all saw during the pandemic how essential these jobs were, and even though they barely get paid the minimum wage, we need these jobs and we need to consider them good jobs. Second, we'd like to require the district's Medicaid agency to rebase provider payment methodologies so that providers can pay this living wage and higher rates for workers, the ones that have more years of advanced credentials or experiences. Next, we'd like to advocate for more resources for training and education so that providers can address these retention challenges and chronic staffing shortages. Sal mentioned this in his last, just a few minutes ago, but the district, not unlike San Francisco, the cost of living is high and there's a significant shortage of affordable and workforce housing in the city. So here are some ideas. We'd like to support efforts to eliminate tuition costs associated with training for DC residents who agree to work in the district for not less than 2 years. 2, we'd like to provide funding, find some funding for home health providers to support on-the-job mentoring to new employees. This is critical. 3, we'd like to provide funding to support the Geriatric Career Builders Apprenticeship Program. 4, establish a fund, a direct care pay equity and education fund, somewhat like we did for the early education community, to fund the needed wage increases and support additional education resources and supports. 5, we'd like to replace the separate credentialing for and between home health aides and certified nursing assistants with a single universal credential. The differentiation between these two jobs goes back to the original way we created Social Security, and home health aides were considered domestic workers and therefore Black people, brown people, as compared to CNAs who were more often white people. This is the discrepancy we need to address. Lastly, we'd like to reinvigorate the Board of Nursing to approve medication aid workers. Here's an idea. We would love to have relevant and knowledgeable Board of Nursing staff and Dr. Ayanna to meet with the DC Coalition on Long-Term Care and other stakeholders to provide an update on the status of the credential. We could then work together in developing training for programs to certified medication training aides. And this is important because we're trying to create pathways for residents to go to get these beginning jobs that are essential and move all the way up to become nurses and LPNs and perhaps even a doctor. And there's examples of this, of people doing that, but right now it's very difficult. So we wholeheartedly support Dr. Bennett for this position. She's got a great background.
Thank you, Neil. And thank you to this panel of witnesses. We have been joined by Councilmember Brianna Nadeau from Ward 1, who is a member of this committee. Councilmember Nadeau, I don't know if you have an opening statement, but you are also here for the public witness testimony. So I'll give you 7 minutes if you maybe want to combine your efforts.
I'll do it in 6 because that's how my day is going today, unfortunately.
Okay, go ahead.
But it was great to hear from these witnesses. I have to say that the reason that I wanted to make sure to pop into this hearing today, even briefly, was because of how important it is who we choose to be our director of our Department of Health. We know that firsthand because we've just emerged from a global pandemic, and we know that every decision our health director makes can be life and death for some people. So hearing this testimony today is really encouraging, as is the very long list of credentials that our nominee has. Not only her experience leading during the pandemic, but really as the Chief Health Equity Officer in San Francisco, we have so many health equity issues here in the District of Columbia, and that truly undergirds everything that we're doing, right? Those inequities are the foundation of so many things that we are trying to fix. So I am very encouraged by her nomination. I'm encouraged by this testimony. Thank you to these members of the public and our organizational leaders for being here today. I look forward to, I've got her written testimony, even though I won't be able to hear her give it live. But thank you, Madam Chair, for convening us today so that we can hold a hearing and advance her nomination. Thank you.
Thank you, Councilmember Nadeau. And again, like I said, thank you to this panel of witnesses. I do have a couple of questions, so I'm going to put myself on a 5-minute timer because I like to practice what I preach in terms of things. I'll start with Ms. Richardson. I really appreciate you being here and talking about the intersection of health and environmental justice. I actually did an event with Attorney General Brian Schwab on this very topic. Well, environmental justice and health issues, but coming at it from a legal perspective as opposed to just a health perspective as well. Are there specific things that like you want to see DC Health doing more on? I know you talked about some of the air quality issues and some other things around the prescription to maybe do a walk, X, Y, or Z. Is it, and I'm sort of trying to tease from your testimony, is it a desire to see more collaboration with some of the other agencies who do this work as well, like the Department on Energy and Environment?
Yes, and I think that, and thank you for asking that question. I think one of the challenges that we have east of the river is that in light of climate change, we are seeing an uptick in health disparities. But it's like, who's measuring how the environmental hazards are impacting our health? And I'm not sure anybody is doing that. So rather than, and a clear example is like what happened this summer. Folks in public housing, in the old public housing, didn't have central air. So they were suffering through the summer worse than the rest of us who do indeed have air conditioning. So who's educating that community about their body temperature? It's one thing about having an air conditioning unit, but who's educating them on what you do when your body temperature escalates and that you collapse or you get too thirsty? I happened to go to a federal workshop where I found out about body temperature and how it can impose on our health disparities. So I think for me, council member, it's just having the health department at the table.
Right.
So we can do better in the communities east of the river, because we're tired of being at the bottom of the totem pole all the time. Give us a chance to move to the top, and we can't do that by ourselves.
I totally understand, and I hear you. I think a lot of it, or some of it is around communication. As the chief public health agency, how are we promoting some more of this information? And to your point about the summer, it wasn't just the heat, but also those few days where we were getting the remnants of the wildfires from the north. So add the heat plus the fact that you really can't open your window. It was just sort of a combination of things, but point well taken, and we'll certainly follow up on some of these issues.
Thank you.
Sal and Neil, you both brought up, issues around long-term care, and I appreciate you guys being here. It's kind of interesting because sometimes when we talk about long-term care issues, it very often comes up in conversations with the Department of Healthcare Finance and not necessarily with the Department of Health. Neil, you gave out specific recommendations of things. Some of them are not necessarily DC Health related, right? Like around the wage issue, et cetera. But are there some specific other things that you want to see DC Health doing in this arena? And again, is it around collaborating and coordinating maybe with DACL and some other agencies, or is it a more oversight of the skilled nursing facilities and helping around some of the workforce issues?
Well, it's all of that, because it's all of these issues are connected. But if there's one thing that Dr. Bennett could do right off the bat is just meeting with the Coalition of Long-Term Care and or DC Appleseed and other interested stakeholders on these issues. The wage issue is critical. They should be part of the table. One of the things that we need some entity to do is to pull in all the agencies that should be communicating and helping inform and make these decisions. So it should be DC Healthcare Finance. It should be the Department of Health. It should be a DACL. It should be a variety of these agencies that are at this point way too fragmented. And from what we know, I mean, maybe things are different, but we don't know. There doesn't seem to be a lot of cross-agency conversations and communication. So that would be a big difference. And I think all the agencies talking together with stakeholders and advocates, I think we could highlight and identify some issues that we could work on together.
Sal, do you want to add something? I know.
Yeah, what Neil said, basically. Everything said. And, you know, I guess my pitch was, you know, this is a lot like herding cats, I think, and a lot of agencies and regulations. So there needs to be somebody or some entity that needs to kind of herd the cats together and try to get something accomplished. So
yeah,
hopefully that'll happen.
My staff sort of reminded me, we do have this entity called Age Friendly DC. It doesn't sit with DC Health. It sits with the Deputy Mayor for Health and Human Services. But sometimes in those situations, you need a catalyst to sort of, hey, light a new interest in a particular issue to get folks to sort of do their pieces on things. And so we'll certainly follow up. I'll ask Dr. Bennett directly around, you know, doing a meeting with the Coalition of Long-Term Care. I imagine she said, we'll say no problem, but I'll ask on the records just so we can have that. But thank you so much to this panel of witnesses. If you have not sent us or uploaded your written testimony on the council website, please do that so that we can have that available for the record when we vote next week. Thank you.
Thank you.
All right, we'll go to our next and final panel of public witnesses, just to telegraph to folks of where we're going. So we're going to do the next panel of witnesses. We'll take a 5-minute break and then we'll come back and do our government panel. So Mary Proctor, who's leadership of advocacy team at Capitol Hill Village, Tamara Smith, who is the president and CEO of the DC Primary Care Association, Rachel Clark, who is the policy director for Redstone Global Center for Prevention and Wellness, and then Christian Carter. Okay, Mary, I see you in the witness room. You need to affirmatively accept our invitation in order for you to become a panelist. So it'll be a little box that pops up. Here you come. Great. Ms. Proctor, when you're ready. Ms. Proctor, if you're speaking, you're on mute.
Well, I set up my computer to actually be visible, but I think it got overloaded by all the heavy duty testimony that preceded me. So I'm going to be speaking to the black box now.
Okay, we can hear you loud and clear.
I'd like to, good morning, Chairman Henderson. My name is Mary Proctor. I am 81 years old and on the advocacy team for the Capitol Hill Village. And I'm very pleased at the testimony that preceded me by Neil Richardson. Oh, wait, sorry. Shoot. Oh, gosh, very sorry for the noise. I would just like to reiterate some of the testimony you heard from Sal Salvaggio and from Neil Richardson, which was excellent on the subject of the shortage of direct care workers. I've been a 4-year member of the Long-Term Care Coalition Workforce Subcommittee. As you know, including CNAs in hospitals, HHAs at home, and DSPs who care for adults less than 65. We welcome, as you've heard, Dr. Bennett to DC as the director of DC Health. I'd like to reiterate several specific issues for the committee, and then one broader goal that you've heard from other speakers. One of the specific issues is to ensure the successful implementation of a program for medication aid training for CNAs and HHAs. Seniors who need help, their families, and the aides who care for them would greatly benefit if care aides were certified to administer medications. This is also a critical element to create a career ladder for CNAs and HHAs that will satisfy strong employer demand for medication aids and attract more applicants. Implementation of this certification has dragged on since 2019 when the Board of Nursing finalized the regulations, but we still do not have an approved program after 5 years. And this reiterates issues of helping the Board of Nursing to do the work that they need to do. A second specific item is the prompt passage and implementation of the critical improvements to CNA and HHA certification. The acting director of DC Health, Dr. Sharon Lewis, promised to submit to the DC Council Health Committee important legislative changes to the HORA legislation by the summer of 2023. And they still have not been submitted to the Committee on Health. You heard from Neil Richardson the list of what's in that package. Of these proposed legislative acts, the Coalition on Long-Term Care I emphasize 2. Lower the minimum wage for all direct care workers to $16. One excellent high school, Friendship Collegiate Academy in Ward 7, was ready to launch a program of CNA training plus paid internships if the HORA amendments were approved in summer 2023. But now the school has to wait until 2024 or later to launch this valuable program. A second item is to combine, as you heard from Neil Richardson, combine the certification requirements for CNAs and HHAs to create one competency-based certification for direct care aides. This quickly increases capacity to train needed direct care workers. But I come back to the broader leadership role. I was very happy to hear also from Sal Salvaggio and from Neil Richardson that they strongly recommend, and from Brenda Richardson, they strongly recommend that Dr. Bennett be a convener of all the people that are critical to the healthcare shortage. Her work in the San Francisco Department of Public Health to increase health equity was across a dozen very diverse health agencies, including jail health services and behavioral health services. This is a woman who has a skill for bringing diverse people together in diverse government organizations. We would like to see a similar leadership by DC Health to link all the many government agencies and programs in creating attractive training, entry jobs, and career paths for direct care workers. This will take leadership of the kind that Dr. Bennett has already demonstrated. Thank you for your opportunity to give testimony, and I'm available to answer questions.
Thank you, Ms. Proctor. Ms. Smith?
Good morning, Council Member and Committee Chair Henderson and members of the Committee on Health. I'm Tamara Smith, President and CEO of the District of Columbia Primary Care Association. I'm here to present testimony in support of the confirmation resolution for the Director of the Department of Health, Dr. Ayanna Bennett. As you know, DC Primary Care Association works to build healthier communities by supporting community health centers, transforming healthcare delivery, and advancing racial and health equity. Our partners in this work include community health centers serving almost 200,000 patients in every ward of the city. Our members serve district residents most impacted by inequity. 95% of our health center patients are racial or ethnic minorities. 88% have incomes below 200% of the federal poverty level, and 37% are best served in a language other than English. We also work in close partnership with the Department of Health, specifically the Community Health Administration, Chronic Disease Division, Office of Emergency Preparedness, the Primary Care Office, the Division of Health Equity, and the Division of Licensure. Our collaboration with the department and the Director of Health is of utmost importance to us and to our community health center members. Together, we work to reduce chronic illness, improve emergency response and preparedness, facilitate licensure of essential healthcare workers, partner to reduce health disparities, and promote whole person care within a fully integrated healthcare system. We fully support Dr. Bennett's confirmation as Director of the Department of Health. Her work in San Francisco Department of Health as the Chief Health Equity Officer enables her to come to her role in the District of Columbia with a strong foundation and knowledge of how to end health disparities. Her leadership and commitment to racial and health equity will support the Department of Health's aggressive focus on improving equity and addressing both the social and structural drivers of health. Dr. Bennett's extensive experience in healthcare service delivery systems and proven track record of building partnerships and growing programs that can drive health outcome improvements for diverse communities, we believe will greatly benefit the District of Columbia. Her attributes as a practicing physician and a public health leader will position the district to be a world-class leader and innovator in the evolution of the district's healthcare system. Dr. Bennett recently met with me and our leadership team at DC Primary Care Association. We were able to share our history, our vision, and mutual goals that will lay the groundwork for ongoing collaboration. We appreciate her willingness to listen, to learn, and her roll up your sleeves commitment to finding scalable solutions to the district's health equity challenges, improving collaboration, addressing system challenges, and improving communication. We have confidence that Dr. Bennett is a leader who will build on the strong foundation and the stellar staff at DC Health and will work to build a healthier community in a strong and resilient Department of Health. Thank you for the opportunity to present testimony. I'm happy to respond to any questions.
Thank you, Ms. Smith. Rachel?
Good morning, Chairperson Henderson and members and staff of the committee. I'm Rachel Clark. I'm the Policy Director at the Redstone Center, which is at the GW School of Public Health. Our center works to address the interlinked public health threats of chronic disease and climate change. And some of our major priorities include access to green space, healthful food, and active transport in DC. And so I want to enthusiastically co-sign everything that Brenda Richardson said in her testimony. The focus of my testimony today will be transportation policy and the role that it plays in health outcomes. Put simply, transportation policy is health policy. Cars and car-centric built environments are leading causes of air pollution, noise pollution, traffic violence, physical inactivity, and climate change, all with profound implications for public health. Yet, transportation is not currently seen as a public health priority. DC Health does not play a meaningful role in the district's transportation planning, and health outcomes are not prioritized in our transportation policies. This is a major oversight. We know that air pollution is a leading risk factor for disease and death, contributing to chronic disease such as type 2 diabetes, heart disease, respiratory illness, and cancer. Recent research has found that on-road vehicle emissions are the largest contributor to air pollution-related health burdens in the district. Vehicle emissions are responsible for over 50% of NO2 attributable asthma cases and 23% of air pollution attributable premature deaths. And this air pollution exposure contributes to health inequities. Another 2021 study found that particulate matter attributable morbidity and mortality rates are 5 times higher in parts of Southeast DC compared to upper Northwest DC. The researchers pointed to congested traffic corridors through wards 5, 7, and 8 as the primary cause of this increased exposure. Cars and car-centric environments also cause traffic violence, a leading cause of injury and reduced disability-adjusted life expectancy. Since Mayor Bowser launched Vision Zero in 2015 with the goal of reducing traffic-related injuries and deaths, traffic fatalities have only increased. In any given month at GW Hospital, 1/3 of trauma patients were injured in a traffic-related incident. At a public roundtable held by the Committee on Transportation and the Environment in May, GW Hospital trauma surgeon Dr. Megan Quintana testified on behalf of the victims and survivors of this, in her words, forgotten area of violence and injury. Dr. Quintana spoke about how even non-life-threatening injuries from traffic violence forever change the lives of patients, their families, and their communities. Her lived experience is supported by an extensive body of research, finding that the impacts of traffic injuries reduce quality of life and lead to long-term decreases in wages and employment opportunities, commonly leading to or entrenching poverty. In the district, the disproportionate burden of traffic violence is most evident in Ward 7 and 8, which have the highest percentages of children, residents with disabilities, and Black residents, and whose neighborhoods are consistently the site of the highest volume of traffic fatalities. Traffic violence has the additional health impact of making spaces feel unsafe for pedestrians and other active users, which limits opportunities for physical activity. Physical activity is a key factor in the prevention and mitigation of chronic disease, and the CDC estimates that physical inactivity contributes to 1 in 10 premature deaths in the US. In DC, more than 1 in 4 residents report no physical activity, a rate notably higher than the national average. Differences in rates of physical activity across neighborhoods exacerbate health inequities. For example, 38% of adults in Ward 8 report no physical activity compared to just 6% in Ward 3. Access to physical activity is, of course, complex and multifactorial, but we know that a built environment that prioritizes cars over other modes of transportation and that creates unsafe spaces prone to traffic violence reduces a community's ability to safely walk, use public transit, or otherwise incorporate activity into their daily routines. In short, the district's transportation policies have profound implications for health and health equity. This has been acknowledged by DC Health in its 2018 Health Equity Report, which calls out transportation as a key social determinant of health. However, to date, DC Health has not played a meaningful role in the district's transportation policies or in Vision Zero. We are thrilled that Dr. Bennett has come to the district from San Francisco, which has been a leader on linking transportation and health policy. We hope that she will adopt some of San Francisco's strategies in DC. Specifically, I want to highlight the leadership role that the San Francisco Department of Health has played in the city's Vision Zero initiative. When San Francisco adopted Vision Zero in 2014, they used police injury collision data to identify targeted areas for intervention. But they soon recognized that police reported data amidst many crashes and near misses that cause lasting harm but go unreported. In 2017, they became the first city in the country to use mapped hospital data to develop their high injury network, which allowed them to include data missing from police data sets and to better analyze spatial patterns of severe and fatal injuries. The Department of Health has also convened an interagency technical advisory group and collaborated with hospitals to create a transportation-related injury surveillance system, a comprehensive database which provides a more complete picture of transportation-related injuries occurring in the city. San Francisco recognized that Vision Zero is a public health mission, and DC should do the same. It should also recognize that the population-level health outcomes and significant health disparities caused by car emissions and car-centric built environments are not solely the responsibility of DDOT and DOEE, but fall squarely within the mission of DC Health. In the Health Equity Report, DC Health called for a health in all policies approach, and transportation policy is a key example of where health should be prioritized to save lives and improve quality of life. Thank you for the opportunity to testify, and I welcome any questions.
Thank you. And thank you to this panel of witnesses. Rachel, I'll just start with you. Obviously conversations around traffic violence and safety is pretty timely because of the hearing that we just had yesterday. We were sort of talking about some of these issues, but I also had a good friend last night who her husband and son were in the crosswalk. A person ran the red light and it was a near miss. And then the person just kept going, didn't stop. So it definitely has implications around health because if it, when we heard this summer of a little girl in, I believe, Ward 8 she and her dad, they were walking to the public pool and got hit by a car on the sidewalk. And so that next time they may not walk. And what does that do for health, or may not choose to go and do some recreation activity? So I definitely hear you and appreciate both, you and Ms. Richardson from earlier, bringing in some of the social determinants of health into the conversation, because that's definitely part of the I think mission and work of what DC Health has to work on. Ms. Proctor, thank you so much for being here and for raising some of the issues that you raised, echoing some of the things from Sal and Neil. You had some pointed commentary about the Board of Nursing. I will say that I think out of the 11 seats on the Board of Nursing, we have like 7 vacancies at the moment that we need to work on. So here is my PSA for all those healthcare workers out there who want to serve. We need you. I also want to mention too that my office will be introducing legislation in I'm going to say a few weeks. Okay, in a few weeks, to address some of the issues or things that you raised around some of the licensing pieces, CNAs, X, Y, Z. In theory, I would love to wait for the HORA, but who knows when that is coming. As you noted in your testimony, it was supposed to be here earlier this year, but I hear it's one more person, just one more. We hope. Ms. Smith, thank you so much for being here and for your testimony as well. Let me ask you, have you had an opportunity to engage with Dr. Bennett so far since she's been here?
Yes, she actually came to the DC primary care office about 2 weeks ago and met with the senior leadership team. And we were able to talk about obviously some of the priorities and challenges in the district. We do a lot of work in chronic disease management, cancer, heart disease prevention. And so, we talked about, the need for, I think a couple of the other panelists talked about how do we have consistent messaging? How do we engage community residents in their own health and well-being? And to be able to have some kind of broad campaign around how we message to residents and how do we promote, the right access to care? How do we promote getting in for screenings and those kinds of things? What I loved about some of the conversation with Dr. Bennett has come up very data-driven, very population health focused, and very clear about the intersection between the social and structural drivers of health and health outcomes and health status. And so I think brings extensive knowledge of how to really address some of these health equity issues that we're facing in the district, and really wanting to bring people together.
That's great. That's good to hear. I know that when she and I met, we talked a little bit about how to get out there and sort of meeting with these various groups who very much make up our healthcare ecosystem and are super important in bringing a wide range of perspectives around some of the issues that we're continuously facing.
Yeah.
But I don't have any further questions for this panel. And I don't see any of my colleagues here. So I am going to say thank you so much to this group. Again, if you haven't submitted your public testimony, please do. Ms. Clark, I will ask some questions around some of the intersections of transportation and health policy. It's very interesting to not only you, but Ms. Richardson and others sort of looking for health or DC Health to play more of a convener role in some of these issues, but not just play the convener role, but have a seat at the table on some of these other policy issues that are intersected and related to the work. So thank you so much to the public witnesses. As I telegraphed earlier, we are going to take a brief break. And so we're going to take a 5-minute break and then we'll be back and we will hear from Dr. Bennett herself. Thank you.
Oh, shit. Stop.
Okay. And we are back. I will now invite Dr. Ayanna Bennett to present her testimony. Before you begin, I will ask that, or I will need to swear you in to ensure that your testimony is accurate. So if you could please raise your right hand so that we can see it on your screen. Well, in front of me, but yeah. Do you swear or affirm under penalty of law that the testimony you're about to provide to the committee and the Council of the District of Columbia is the truth, the whole truth, and nothing but the truth? Great. You turn your mic on. There you go. And when you're ready.
Good morning, Chairperson Henderson, council members, and staff of the Committee on Health. My name is Dr. Ayanna Bennett. Not quite close. There you go. How's that? There you go. I'm the acting director of DC Health. I'm pleased to be here today. I'd like to first thank Mayor Muriel Bowser for appointing me as director of DC Health to move forward her vision of health, well-being, and equity for the residents of DC. I share Mayor Bowser's commitment to that vision, with equity being my professional focus for over 20 years. I could not have chosen a better team to work with than the staff at DC Health. I have witnessed their dedication, passion, and creativity as they work to promote health, wellness, safety, and equity for residents, visitors, and those who do business in our nation's capital. I've also been welcomed by DC Health's sister agencies who have universally been eager to partner and work to creating a healthier future for all district residents. I also want to thank you, Chairperson Henderson, on behalf of the DC Health team for your support of our work advancing public health in the district. I appreciate this opportunity to come before you and demonstrate my deep commitment to the well-being of our communities and to assure you and the committee that I'm both qualified and ready for the role. As you know, I'm coming to you from across the country as a lifelong Californian. I'm arriving at a time when the district is facing serious health concerns, protracted health disparities, community violence, serious mental health issues in our youth, and the continuous impacts of the opioid crisis, among many others. As a new neighbor, I want to share with the district who I am and what has brought me here to help find solutions to these critical challenges. I was raised in San Diego in a working class community. I went to public schools from Head Start through high school and then earned a scholarship to Stanford. After graduating with a bachelor's in human biology, I stayed in the Bay Area to complete my professional training. I earned a master's at UC Berkeley School of Public Health and a medical degree from UC San Francisco. I continued at UCSF to complete my residency in pediatrics. I then went into the community to start my practice in general pediatrics and community health. My professional journey has included work in many different parts of the health landscape. I was a partner in a private practice in the suburban town where I lived, seeing my neighbors' children in my office in the hospital. At the same time, I worked with a coalition of neighborhood residents to establish the first clinic for youth in an underserved, historically African-American area of San Francisco. The stark differences between those professional tracks strengthened my belief that both private sector healthcare and public health institutions have important roles to play in protecting and advancing the public's health. I took both my clinical and community health experience in San Francisco into the San Francisco Department of Public Health, where I became the first a clinical leader for youth services, and then joined the Office of the Health Director to lead equity projects. That role was formalized as the Chief Health Equity Officer when I established the Office of Health Equity for the department. From that position, it became clear to me that the health ecosystem struggled to move past the awareness of health disparities to eliminate inequities in care and create new approaches to service that could actually reduce those disparities. My focus for the last 8 years has been helping public health and healthcare institutions develop and implement best practices and policies to create real sustained change. Where we deliver services, who gets invited to the design table, and what behaviors we expect and monitor in our staff are all levers to reducing health inequity. I believe that urgently and actively pursuing those changes is the obligation of everyone working in healthcare and public health. I've been part of that kind of change and seen the impact it can have. I have worked with public hospitals, clinics, and behavioral health centers to reduce and in some cases eliminate health disparities. We did that by defining a standard of unbiased care and monitoring data and patient feedback to ensure those standards were met. We redesigned services and staffing to meet the specific needs of the most vulnerable patients. We redesigned, I did similar work with our public health services, including environmental health, food security programs, HIV services, and maternal child health, among others. Those programs changed their funding practices and service development to increase the voice of the community in their decisions, and tailored services to directly target particular disparities. That's especially true in those communities that are often overlooked. These two lines of work in healthcare redesign and public health program development culminated in 2020 when I served as the leader of the health response to the COVID-19 pandemic in San Francisco through that first tumultuous spring and summer. I credit much of the success of that response to the skills staff and leadership developed doing everyday improvement and innovation to advance equity. The ability to quickly develop relationships with different communities, to use data and staff experience to localize needs, and to correct inequities in practice and access in real time. My leadership in both clinical and public health settings allowed me to easily step into the role of Chief Health Strategist for the district. DC Health has a unique dual role as both state regulator of healthcare workforce and facilities and the provider and funder of community health services. I will build on the existing work at DC Health to create a nimble and outcome-focused public health workforce that uses the tools and infrastructure built during the pandemic to address the deeply rooted inequities in our communities. I'd like to now give you a sense of how I will apply those skills and approaches to lead DC Health into the future. I want to start by recognizing my predecessor, Dr. LaQuandra Nesbitt, for her heroic work in guiding DC government and residents to rise to the challenge of the COVID-19 pandemic and lead DC Health's successful pandemic response. I'd also like to thank Dr. Sharon Lewis for her generous work as interim director, while the department and the district began the path to recovery. DC Health has emerged with a new appreciation for how innovation, collaboration, and real-time data can allow us to respond effectively to the greatest public health threat of our lifetimes. I've joined a team both aware of its strength and eager to become even stronger. The next challenge for the agency and all public health agencies in the country is to take the skills we developed during the extraordinary circumstances of the pandemic and make them part of our routine practices. Our success in the pandemic is a roadmap to a more effective, more responsive DC Health. So what was the source of that success? Actionable data, authentic community partnerships and communication, the active pursuit of equity, and both internal and external accountability. We must now turn those tools to our central mission, the promotion of health, safety, and equity in our communities. Health equity can be achieved through improving our existing data systems, expanding our team's ability to understand the root causes and impacts of policies and programs on outcomes, and an increase in the proactive development of policies, practices to improve population health. I believe we can achieve this through an intentional analysis of our existing programs, initiatives, policies, and targeted use of quality improvement tools to direct innovation. We will also move towards a more prospective approach to policy, crafting solutions to problems that we know are coming down the road, not only working to address problems that have already become crises. DC Health made significant strides during the public health emergency in linking data systems and using data to guide decisions. I'm working with staff to identify remaining gaps in data and data capacity that, when filled, would give us the necessary depth of information to tackle heart disease, infant mortality, food insecurity, and the other health problems that plague our communities. When we have a full picture of what is happening in the community, we can be more responsive and more effective. We have also learned to use our partnerships to meet big goals. Our community partners have the deep experience to reach even the most isolated residents with education, medical care, and resources they need to have an equal opportunity to achieve good health, well-being, and longevity. With our institutional partners, our hospitals, providers, partner agencies, and universities, we can create shared goals and collaborate to address the complex drivers of health inequity that DC Health cannot address alone. These connections were tested and expanded in the last few years, and we know what we can achieve together. DC Health should and will be the leader and convener of those efforts. Lastly, we must continue to embrace transparency and accountability that the community relied on during the pandemic. We must invest in our communication and data systems to allow the public to understand the state of health in the district, the priorities we've set, and our progress in achieving those goals. Building off DC Health's culture of quality report, we need to expand our quality improvement capacity and practice to ensure we are delivering quality services, from licensing health professionals to educating families about health literacy. We're capable of excellence, and our communities have the right to expect it. I accepted this opportunity to lead DC Health as a natural next step in a career focused on improving systems to achieve health equity. I believe the district is a place where that vision can be realized, though there are challenges. DC Health has both made great headway and encountered real barriers to achieving the future I described earlier. This moment in public health is one of necessary transformation. We have been through the biggest test our profession has ever faced. We cannot simply return to our pre-pandemic work without incorporating that experience. A significant number of the staff at DC Health are new to public health, starting their careers during the pandemic. I see my background as a clinician, community advocate, and public health leader as a good fit for this team of new professionals and COVID-19 veterans. And together we will build a culture of innovation and excellence that will carry DC Health into the next chapter. I also have the background to turn that innovation and excellence to the task of advancing health equity. I've seen the root causes of health inequities in both my personal and professional life, and have been able to craft effective solutions to these in previous roles to reduce those inequities. Thank you again, Chairperson Henderson, committee members, and staff for the opportunity to present my qualifications and vision for DC Health. I'm thankful to Mayor Bowser for trusting me to lead DC Health at this pivotal time for public health agencies. I'm available to answer any questions you may have about my qualifications for the position. Thank you.
Thank you, Dr. Bennett, and thank you for that extensive testimony. I will have some questions. I do want to say we have been joined by Councilmember Gray, chairs the Committee on Hospital and Health Equity. Councilmember Gray, do you have an opening statement you wanted to provide?
Thank you very much.
Oh, hold on one second, Councilmember Gray. We can't quite hear you.
Okay, is that any better?
Yes, sir. There you go.
Okay, thank you so much. I'm glad to have you there to join us in this participation, and we'll be happy to hear from you when you participate further in the effort today. So, thank you.
Great. Thank you, Councilmember Gray. I know that I have several other colleagues who do plan to join, so we're going to do 10-minute rounds. I want to start in sort of talking about your agency management and previous experience. You talked at the end of your testimony about some of the workforce issues, not specifically across DC writ large, but in DC Health in general. DC Health has struggled with some high turnover and many vacancies within the agency. I believe in FY22 was a 24.5% vacancy rate. What's your plan in terms of recruiting individuals to fill those vacancies and overall decrease the turnover rate for the agency?
So the entire industry, and among really all of healthcare and public health, is in a time of turmoil in terms of our workforce. So we are trying to increase recruitment in an environment where everyone else is doing the same thing. So that is the context of my answer. I think part of our approach has to be to do something totally different than what we're already doing. So whenever there's a problem that we have failed to solve, I usually think there's a reason that our solution may not be quite a match for our times. I think on some level, the people we're looking for are not there. They've either left the industry or they are newly interested in training. One strategy that I have seen be effective is to raise people from within the agency and then fill those frontline positions behind them, which is a lot easier to do. So that is internal advancement is one approach to take to that. There are a lot of other solutions put forward in the workforce recommendations that we've just released. And I think many of those will solve the problem over time. So they're about training, they're about moving people from one place to another. And those are solutions for 5 years from now, 4 years from now at the earliest, probably. And we should start that right now, because we're going to still have this problem in 4 or 5 years. But looking internally, looking at moving people who have skills outside of public health, just some of our, we do things with data. We do things that are really just about communication or some other need that doesn't necessarily have to have the public health knowledge behind it, because we have plenty of that. And so recruiting for skills and not necessarily matching background is another approach to take. And it just means we have a lot more investment to put in on the front end, but we're putting quite a lot of investment in recruitment already.
Right.
So we should probably be looking elsewhere for what our strategies are.
Okay. That's good to hear around recruiting for skills and not necessarily for background and experience. I often hear sometimes from employers is that they're looking for thinkers, people who can think. They're looking for problem solvers, and they can teach you some of the other stuff, but a desire and curiosity for learning is like the central thing that they are looking for, and the ability to write. That is, it seems basic, but it is a challenge for some of our folks. Well, I know that in the FY24 budget, we did provide DC Health with some additional positions in the area of HRLA and licensing, but also in particular, I'm forecasting for you. The folks behind you know what happened last year earlier this year around food inspectors in general. So I'm going to be asking you that during the performance oversight hearing. How are we doing in that particular area of recruitment? Again, forecasting. So by January, I'm hopeful that you will have filled some of those positions that we've provided. Across the divisions, DC Health, it's not just DC Health, it's a lot of the agencies have had ongoing challenges with publishing data and reports in a timely manner. This is particularly problematic as researchers and advocates have relied on data collected by this agency to plan effective public health interventions, particularly in the areas of HIV and AIDS treatment, maternal and infant health, and some other areas. That said, we know that DC Health is capable of publishing timely data, as we saw with the COVID dashboard for over 2 years. What's your strategy for ensuring that DC Health is publishing data and reports in a more timely manner?
So I just want to firstly say, I believe very deeply that transparency is one of our central obligations to the public. People are better able to do what they need to do for their health or the people they care for when they know what's happening. There is also a reality that what we did during COVID was enormously funded from outside, included people who, were brought in temporarily and no longer are there, funding sources that are gone. So what we now have to do is go back and see what infrastructure have we built that can be used to those ends. Where don't we have the data? Sometimes people are asking for data that's actually not collected or is not delivered to us because there isn't an obligation to do so in a timely manner. That is true for many questions. I think those can be untangled. That's, as everyone behind me knows, data is it comes out of my mouth multiple times a day.
Right.
So we will do better than we have been. I do think there's going to be some restructuring that has to happen about the relationship of data between agencies, between us and our partners, because we don't necessarily collect everything that we're going to need to make real decisions. And the communication between our community partners and us around what data they need and what actually needs to be published and how often those things need to be, that conversation has not really happened yet. So something that we publish once a year that needs to become once a month, that is a structural change. So it is a staffing change. So people are doing something now that we need them to not do in order to be able to do that. So it will take a little time. But
how many people at DC Health is in the data team?
I don't know off the top of my head. I've learned quite a lot in 2 months, but
there is a data team.
There is a data team. There's a data management team. we are basically somewhat retreated back to our pre-pandemic department,
Okay.
which was not heavily invested in the communication of data. The analysis and collection to some degree, yes, not necessarily the communication of data.
Right.
Lots of data is collected to report back to the federal agency that paid for it.
Which again, I'm not trying to say reinvent the wheel. Sometimes it's that information that you're providing to CMS or CDC or HHS is the very data that folks are looking for here that they want to find, whether it be, you know, we have a lot of college students who are in the area who are doing reports this time of third, NIH, et cetera, local community-based organizations who are just interested in sort of learning more. And it's not just with you. I've had the same conversation with Aussie around what is the educational data that's available. It shouldn't take a FOIA and a data request to find some basic information about graduation rates and turnover and those kinds of things. And as you said, sometimes it's data that we don't have, but I'm grateful to hear you're saying that data is at the forefront of the things that you like to talk about. And so maybe some sort of, I don't know, data code crunching summit. I don't know what it is, but as you said, like, what are the things that you have? What are the things that people want to see? And what are some of the structure pieces? So I look forward to hearing more about sort of your work on that front.
That's my number one priority. Just so you know, literally my number one priority is getting the data right.
Okay, great. I love to hear it.
Because I can't do anything else without it.
That is true. And so I want to actually talk a little bit about how you infuse data in some of the previous work experiences that you had. So in your role as director of the interdivisional initiatives at the San Francisco Department of Health, you were focused on improving effectiveness, equity, and collaboration across the agency. I'm particularly interested in the interagency Black African Health Initiative and the sexual orientation, gender identity data projects. You led this work. What did these projects entail and how did you define success?
So the BAHI, the Black African American Health Initiative, was an attempt to get the public health side of the department in San Francisco and the health delivery system, which the city owned, to work together on Black health issues that the department had itself defined. So we had done all the work on years of life lost and differences in life expectancy and published them, but then not had any effective internal action on those issues. So the BAHI project picked 5 particular conditions to focus on, and I will repeat again and again to people, you have to pick something. You cannot fix everything at once, and if you don't declare yourself somewhere, you won't do anything. So we picked 5 conditions. It turned out really that there were 3 that were effective: heart health, chlamydia, and then early on alcohol, and then later a little bit of breast cancer. The heart health, I think, was the most successful. That would really tell you how that collaboration could work. Our granting from the CDC, those staff who were doing heart health and chronic disease based on those federal programs were moved into a collaboration with some of the health clinics that had a heavier Black presence in their patient population, and they met on a monthly basis. So one of my standards is that a collaboration is a physical thing. You should be able to see something. It's a meeting, it's a newsletter, it's a shared budget, it's a something. If there isn't anything there except the idea that we work together, then you actually don't have a collaboration. So they met every month. They had a monthly, they had a set of deliverables, and that was a statement that all the nurses said every time a Black patient came in. They said it at least once to that patient about how this is our commitment to getting really it was hypertension equal between all our patients. And we know that you're in a group that is not being served well. We changed the staffing so that the person calling for reminders was actually a nurse who was a community member and lived in that neighborhood. And so it changed dramatically the ability for people to show up to their appointments. They just had a different relationship with her. They changed the structure of visits so that there was a nurse and a pharmacy visit separate from the doctor visit that you could schedule for any of those 3 things, partly because people had time constraints or a relative couldn't come, and they needed someone else to come for the pharmacy part, but not this other part. So we structured each little change around communication with the patients about what is different that you need from everybody else in order for you to successfully manage your hypertension. The other part of that was to connect and right size the social supports around that. We did have a activity prescription program. So the public health side paid the YMCA to give memberships to people, and those memberships were activated by a prescription from the doctor. And then they developed their usual exercise program into a neighborhood walking program because we were sending them elders and not 30-year-olds. So we worked, and actually they had, and then we did ethnographic research in the neighborhood on those particular patients to find out what are some of the drivers. They went to the grocery store with them. They went to some of their doctor's appointments. They talked to their family members and worked out some things about what was unique for Black men, what was unique for Black women who were in the child rearing years, because we were having people who were sick 15, 20 years earlier. So people were beginning their hospitalizations in the data. Black patients were beginning their hospitalizations of their severe hypertension in their late 30s. And so we needed to talk to actual working women, not older women, like you would think if you were just looking at hypertension generally. Men said very emphatically that they listened to other men. They let their wives and their mothers do all the care, but then they were listening in terms of what they did to the older men. The older guys wish someone had told them. And so we used the barbershop model that's been used in other places, but we actually combined it with a discussion group that we had for younger men. And we bought barber chairs for the YMCA and hired a barber. And that person came to their usual focus group and told everybody to bring their uncle or their dad or somebody. And they kept that going after we did it the first time. That we paid for it a few times as a special communications project, and then it became a program and we funded it as a program. So trying things, we did other stuff that didn't work. Trying things, trying to right size your program with what people actually need. There's some difference in the community, either the way they relate to it, either the way you're relating to them. There's a difference that's making that inequity happen. And so actually believing it's there and not an inevitable part of just being poor or being Black, or you have to believe that there's something that you're doing. And once you do that, figure out what that is.
Yeah. That was great sort of hearing those pieces, not just sort of the innovation piece, but that the particular interventions were data driven based on not just data, but also conversations where you said like the Black men were saying, well, we actually just want to listen to men. And so how do you pivot to sort of make that change? And I especially like what you said around collaboration as a physical thing, because I feel like often my new saying about DC is that we are resource rich, but we are collaboration poor, because we are collaboration in name only, but no one is meeting or talking or physically doing the action together. We're just saying, oh no, we've got this thing, we're working, but it's not really meeting. So I'm going to use that against some of your colleagues and some of the other agencies.
Don't say it was for me.
So you talked obviously you have a background in health equity. You've been here with us since July. So you've had an opportunity, I say, to do a sort of road show within your own agency to figure out what's going on, what are we currently working on, what's coming down the pike. How would you compare DC's Office of Health Equity to the one that you led in San Francisco in terms of what you think needs to be done a little bit different? And that's not necessarily to put them on the spotlight, but that's specifically what you worked on.
There's a broad array of approaches, partly because we're all kind of making it up. It's not a set of best practices that everybody do it this way. At this point, the health community, public health, industry, we're all kind of just starting to decide what that is. The position I had in San Francisco was a deputy director position in the office. I had at first no staff, and then I had a moderate staff when I left. I think I was up to 14 or 17 FTEs by the time I left. that was a slow evolution over those 7+ years. That led me to an approach that was scrappy, if nothing else, partly because there are 8,000 employees in the San Francisco Department of Health. It includes two full hospitals, 32 different clinics of different kinds that are not physically next to each other. Some are behavioral health, some are youth. So the variety of spaces and places that I would have had to try to impact was fairly vast. And so my approach was to support them changing themselves. So we say equity is everybody's work, but unless you are telling people what that means, again, it should be a physical thing. I should be able to see what the equity in your work is. Then you really aren't realistically expecting them to do much. If we're all making it up, people who it isn't even their central job are maybe not going to get there without some support. So what I did is create tons of infrastructure. There were multiple levels of governance. There were committees. There were champions who had, permission to take 60 hours out of their work year to devote to these projects. There was a fellowship. So I created lots of infrastructure because I couldn't physically be anywhere. The infrastructure that the Office of Equity at DC Health has created has not so much been in the different administrations. It's been very outward focused, which in some ways is very important because we do need to be the convener. People are asking for us to do that. I don't think that we've had the shared vision of convening with that among all the other agencies on every issue, because I think they've had to struggle a bit to be part of conversations that I would expect to see the Office of Health Equity at. Vision Zero, I'm used to it being a DPH project, frankly, and MTA came on and eventually we handed it back to them. But that was after the the walking school bus was in place. That was after the injury network. And that didn't happen here for various reasons. And that's true for multiple collaborations. So I think the mandate being supported across the board to be a physical thing, like you should have committees, like what are your committees? What are your plans? I think that's coming here. The racial equity action plans, the structure where we all have a shared expectation that something's going to happen. And then the job of the Office of Health Equity is to convince you that our thing should be your thing that you have happen, but it's going to be something. It's just a very different position to be in. So I think we are lacking the internal work, and that's just because the expectation wasn't set that everybody would have something. I should know what disparity any particular part of the department is trying to close. Just wanting to have disparities close in general is not going to result in anything. But at the same time, I've seen very focused, innovative work. We're going to be awarding people for innovative work because it's happening. It's just not scaled and spread and standardized as an expectation across the board. So I'm going to lend the authority to make that something that the Office of Health Equity can do, because it can't do it without that. And so I think there's been some missing piece, both the distraction of COVID and the kind of long interim period. We're going to come back. I think we can tighten it up.
Hi. I'm going to stop briefly and turn to Councilmember Gray. Councilmember Gray, I don't know if you have any questions for Dr. Bennett based on what you've heard thus far.
For taking the time to come and be with us. Any questions that I have now, we'll just that will continue on in the next minutes. Okay, yeah, Councilmember.
Okay, I will stop periodically just to check in, see, or if you turn your camera on, if you have some questions, and then I can see you and then call on you if that's okay.
Thank you.
All right. During your time in San Francisco, what was the relationship like between the Department of Health and the Board of Supervisors? And in that, what would you like the relationship to be between DC Health and the council to look like?
So between the Board of Supervisors and the department stood the Health Commission. So the structure is somewhat different. The Health Commission was appointed by the mayor, and it was made up of mostly people from the healthcare field, but not completely. It's, trying to represent every community. So it was a little bit of a different relationship for the oversight part. So our budget went through that group before it went. So, there's a little bit of a slight distance. But the Board of Supervisors was actively involved in big projects with the Department of Health. Our alignment of the mental health system in the city. There were big projects that were sort of shared visions with particular members of the Board of Supervisors. I will say that anytime, at least from my perspective, we were going to do something that was big, it needed multiple different stakeholders in it. I very easily found that someone on the Board of Supervisors was interested in being the support of that. The support in that case is not of the department, it's of the stakeholders who want to be involved. It's of using those contacts that they had in the community to try to pull people forward, to help aggregate voice about what the actual problem was when we maybe had an inkling, but not a true on the ground sense. So I think we worked well together, but the roles were slightly different because the commission sat in between.
Okay. But how would you like our relationship to work with the council?
I really respect representatives as representatives. So I've heard even already about questions that people are asking. If people choose to ask their council member, that's still them asking the government. So those questions should come to us and we should be open to answering them. It's a way to understand what the residents are saying. Not everyone is a patient. Not everyone is a client of some community group that we fund. So there have to be multiple ways for us to hear from the community. And that is, a central part of your role. The other part I think that's important is when we're balancing priorities I would like the opportunity to be very specific about what health's role in whatever conversation we're talking about, because I think sometimes the assumptions don't always match the reality. It's a complicated field in many ways. So just having the opportunity to explain what it is we're asking for or how we see a question when health and other priorities are being balanced as they must be. That's really what I hope our relationship will be. Just opportunity to help clarify things, to help give information where there may not be enough to make a full decision. And just the assumption being that we might have some more information and that you can rely on us for it.
That's great. Obviously, you have deep experience in addressing the COVID pandemic. I talked a little bit about that in my opening in terms of your role co-leading the emergency response in San Francisco for both the city and for the county. We're heading into the fall, winter, although you can't really tell from outside, but next week, apparently real fall is starting. And with that, respiratory viruses, COVID, flu, RSV, will likely follow behind its weather cousins. How are you instructing the staff on effective ways to educate the community and the public around these various respiratory issues, especially given both COVID fatigue, but also a rise in vaccine hesitancy?
This is going to be a hard year, not necessarily because of the burden of disease. And knowing that, being able to predict that, I feel like is my role. And so I've asked the staff to be working on this as a collaboration across administration since early August. And we've had a plan that we've been executing since that time and refining. There are real barriers to effective work in this area this year. One of them is that the commercialization of COVID vaccine has made things incredibly complicated. So we've trained people that it was going to be free and they could go wherever. That is no longer true for much of the population. It is still going to be covered by their insurance, but the mechanics of that are the multiple suppliers, different people ordering at different times. It is more complex because it is in our normal, very complex healthcare system. So we have been messaging really around that, trying to get people to understand that they still need to take an active role in protecting themselves, and that they're going to need to question and go out and engage in order to do that. There aren't necessarily many ways in which we need to mass vaccinate everyone. I think we're back to focusing on very high risk groups in terms of where DC Health puts its effort.
Mhm.
So we'll be doing vaccinations at home, vaccinations of groups, matching providers with institutions that want to do vaccination of their constituents. We will be doing all of that work as our support for vaccination across the most vulnerable. But our other job is to support people who are not in that group, trying to figure out what they're supposed to do. And that is what most of the questions from council members who've been passing on constituent questions have been about.
Yeah.
We are trying in the minute to keep up with the changes in the way the vaccines are being distributed. There's lots of CDC support for that this year in terms of being able to predict the season, which is likely to be somewhat like last year's, which was a little rough. Trying to get people to understand the difference between the flu, COVID, and RSV vaccines, which have different levels of availability,
Right.
and different groups for whom they're recommended. So it is a complex year, and it's our first year doing it in this much more complex, but really our normal American way. So we're messaging around complexity. So it is a nuanced message, but we have been working with media, working with our CBO partners, our community-based partners very closely to make sure they understand what's happening, because a lot of the information people are going to get is going to be asking individually and trying to get them connected with somebody who can talk them through it.
Yeah.
Not just here's the address and go get it. It really, unfortunately, can't be that simple this year.
Right. I even, the online commentary from folks of trying to communicate. We did this very broad public thing where we gave free vaccines, free tests, free this, free that, and trying to explain to folks like the federal funding and flexibilities that allowed for us to reduce some of those barriers are just no longer there, which makes it really difficult, even though you're asking DC government to do some of these things, it is not the same. I can't tell you how many questions I get from people of like, well, why can't we just take the vaccine to the schools and just jab the kids as they walk in? And I'm like, okay, well, I need parental consent. I need to know whether or not you have insurance of who we charge. We need a refrigerator. Now I know all these things.
Yes.
I got to keep it at a certain temperature. We need a clean area, all of these different pieces. And so I worry about more specifically RSV, particularly in kids, particularly in seniors, because it was so nasty last year. And it has very similar symptoms as some of these other respiratory diseases, but people are, oh, I can drink my ginger tea and I'll be okay. And I just, how we, and sort of part of the plan, you say you all have a plan. As part of that plan, sort of working with DACL and some of these other agencies, maybe it's going to the senior wellness centers and having a conversation with those, they're more active seniors because they're coming to the wellness center every day, but they could take it back out to the phone tree and say, hey, this is what you need to do. This is how you get it done. And this is how you protect yourself.
We have been messaging out to the other agencies about these issues as we did to council members. We, for the most part, are working through our connections with those agencies we have CBO partners who work through them to do the healthcare support for those kind of agencies and trying to get them to be the conduit for a lot of this information.
Yeah.
I don't know at the moment how well that's working because we're just looking at people having availability quite recently in terms of being able to see whether or not people are getting it.
How do we track surveillance around
the same visibility we did with COVID? So we don't know who has what necessarily because they don't don't have necessarily an obligation to tell us. We are working with people to do vaccination. And so there is a cooperative relationship there, but it is not the same landscape as it was when we had our hands on everything and we were acting as an arm of the federal government. I'm quite worried about RSV too. As a pediatrician, I spent many winters walking through hallways full of babies who could not breathe well. So I know we need to be prepared. We're currently even talking to children's about their beds. So we are trying to prepare. I will say that we are preparing within a fairly complex landscape of very recently released and not necessarily well-known vaccine and monoclonal antibody therapy for RSV, very recently released new vaccine for COVID. So the lead time to do the kind of public education that you usually need to do to get people to find something acceptable is not really there this year.
Okay.
So the likely coverage that we're going to get is unfortunately not going to be as good as it hopefully will be next year. And in the future, it's going to be a difficult year.
Okay. One of the things that perhaps would be nice, because I hear from parents in terms of DCPS and charter schools, they're upset in terms of the reporting changes that have been made there, but children's being the largest in terms of the hospital and clinic structure for young people, if we could ask them to just go one further step of when you see a case of RSV, instead of just asking the parent whether or not the child is in a congregate care, asking for the location. What school does the young person attend? Because if we start to see 15 cases from the same school, we can inform the school, hey, there's an outbreak going on. And so we are making a suggestion or a recommendation or whatever. Your school might want to do masks for the next month, or you might want to inform the school community, hey, we're seeing an increased tick in RSV cases here in our school setting. There's a vaccine available. Make an appointment with your pediatrician. It's just I feel like there is a piece that is missing that I can't really inform the public around, like, so-and-so elementary school is a hotspot right now.
So the high-risk group for RSV is not most of our school age kids. So it is a very young child. It really would be, I'm going to replace childcare centers in that conversation, and it's the same conversation.
Okay, thank you.
Part of getting the data is figuring out which of our levers we actually have to do that. Do we have regulatory authority to get that piece of data? Do we have a relationship to get people to give us data voluntarily? And can we make it easy enough that we believe that they are consistently giving it to us? I don't know if that's true at the moment for really any of those, but we do have some elements of surveillance that we can use, including what people are entering the ER with. We have a lot of influenza-like illness, which we know based on the wastewater is likely COVID. So there are ways to triangulate around what that information is. And I think we will have some ability to do that. The very targeted work that you're describing, that is what I think needs to happen on almost every issue in order to use our resources well. I don't know how well we're going to be able to do that right now.
Okay.
We do have some information. We do have some.
We can work on that, because I think that sometimes fear is associated with just knowledge, not knowing. Right. And then for families who have autoimmune diseases, et cetera, just information to help them make better decisions about how they're going to go on with their daily lives. Part of this conversation, we talked a little bit about this when we met in August. I encourage you to meet with and tour the public health lab. Have you had an opportunity to do that? What do you think in terms of opportunities for further strengthen relationships and increase collaboration?
We are lacking the physicalness of our collaboration.
Yes.
So we did talk about how to fix that. We are entirely dependent on the existence of a public health lab. So their health and well-being is our problem. So I'm very committed
Okay.
to them getting whatever it is that they need. But in order for us to really have shared planning and shared execution, we have to have a more formalized structure of interacting. We've got financial MOUs, but not necessarily defined and ongoing conversation. So we are working on that, and the medical examiner and I are going to be on a couple things together. I invite him to something, he invites me. So it's building.
Okay. It's a work in progress. That's what I want to hear. The joys of when none of my colleagues come, I have to keep going because we still got to get to the questions. So I'm just keep going. We're going to get through this. Don't you worry. So Dr. Bennett, Ms. Richardson earlier in the public witness testimony talked a little bit about air quality issues and things like that. Childhood asthma disproportionately affects children of color in the district, with 17% of Black children and 21% of Hispanic children experiencing asthma, in comparison to about 7% of white children. This is related to indoor air quality, mold, outdoor air quality, and other factors. And I also serve on the Committee on Transportation and the Environment, and have been trying to work with the Department of Energy and Environment in terms of stepping up their regulations and inspections, frankly, of mold and mold remediation in housing and other areas. Well, we need to do a better with the Housing Authority. What do you see as DC's health role in addressing this health inequity?
So first, I don't think we need to own every piece of something to have an obligation to be part of it. The environment in which people live is such an enormous factor in their health that for us not to be in the conversation is to essentially concede a big part of our impact. So I've already talked to the director about what we can do together. I do think the home environment is a essential first contact for folks who you otherwise want to engage on a myriad of health issues. Removing the mold from somebody's house is a relationship builder that gets you to talk about food, about elder health, and 50 other things. So understanding the home as in the way it's understood by the people who live in it as their primary concern in many ways, I think is something we need to work on. And the not having all of the environment within the department is different for me, but I can partner. And I do think we have a footprint there, and we need to make some really formal partnerships, particularly around children and indoor environments, because it just is too large an issue. I think focusing on asthma or there are a few things that we could focus on to make that real: lead, asthma, but we've got to pick something and then try to build a relationship around that and shared teams. Maybe we do shared visits. I'm not quite sure, but we need to build a program that puts us in the home to say, this is healthy, this is not healthy, because for the vast majority of it is going to have to be managed by the people in that building.
Yeah. And it's not the mold piece in terms of air quality too. Earlier this year, we had a witness who's fairly persistent around hoarding and how that impacts air quality in the home. And I've definitely got an earful of that from Chief Donnelly in terms of how that has impacted just safety in general. When there is a fire emergency and you have a lot of
material to burn
in your home. But one area that I really would love to see DC Health help. So next week, we're marking up access to emergency albuterol and glucagon legislation. And I see some of your staff, they testified on this hearing, and we're moving that forward. But the shocking number of students who do not have an asthma health plan on file at a school in comparison to who has asthma, gives me heart palpitations. And I feel like that's a I don't know if that's a communication of DC Health to pediatricians around you have to drive this home. You know who the young people are who have asthma. So why can't we work with families in sort of getting this I feel like the emergency access is a backstop, but it shouldn't be our primary. And we really need to increase I think it's only 15% of kids who have an asthma health plan on file in comparison to who we know have childhood asthma. I want to turn to talk a little bit about diabetes, which is type 2 diabetes is a chronic condition affecting over 43,000 district residents, disproportionately, again, affecting residents of color. At a hearing with United Medical Center, which falls under this committee's jurisdiction as well, the hospital testified that approximately 40% of the patients who come into the emergency room also have diabetes. So it's a very high percentage in certain parts of the city. DC Health runs the DC Diabetes Prevention and Control Program, but it's unclear what resources are offered through that program. And the diabetes data available on the DC Health website is from 2011. So I know you like data. Can we work on that?
So my intention is that the things that are the most significant drivers of health and longevity in the community should be ones that we collectively are working on together. And that's the kind of thing that you need, if not real-time data, as close as we can get to it. Diabetes is on that list. Hypertension is on that list. Some of that data is going to be a conversation with our primary care providers, with healthcare finance around the information exchange. There are conversations to be had to get that clarified.
But what
Some
is
of
the
that's
program?
just posting the data. It's a
It says
different program in different places. And I have spoken to every part of the department, and I honestly don't remember what the particulars of that program were, if I've heard it,
Okay.
but I'm happy to go back and learn more about it.
Okay.
In particular, our role in getting clinical sites to have better connections with, chronic disease management and lifestyle outside of the office is a central concern of mine.
Mhm.
That's what I would like us to be focusing on for all of these programs. So I will look into what it is this program is focusing
Okay.
on, but
I
I
mean,
have to go ask the team.
So speaking of critical disease management, have you talked to any of the MCOs since you've been the presidents of the plans? I know they deal more with healthcare finance, but they are truly doing the quote unquote management piece for more than half the population in the district, a particularly high number of young people who are on Medicaid in the district.
Yes. Do not quiz me on names. I'm begging you.
Okay, I'm not. But I'm just saying, in general.
Particular weakness of mine.
But yes, you have talked to some of the plans.
Yes.
Okay. I think that is an area to push more. It's certainly an area the committee will be pushing more, especially as we're about to launch the behavioral health carbon for the Medicaid MCOs. They have a lot of data, they have a lot of responsibility, and they're very expensive.
And a lot of connections. They have the direct connection to the providers and could and have done in many parts of the country do innovative work around helping the providers improve because they actually have some leverage, which I don't necessarily have. So where innovative work is happening, and it is, I think part of our role is to find it, to figure out whether or not there needs to be a regulatory or legislative support for that to happen other places, and whether or not we can support the people outside of that group who maybe aren't seeing that innovation.
Okay. Approximately 880 district residents have sickle cell disease. We are one of the highest rates or jurisdictions here in the district. And for a large percentage of these individuals, it's not managed well for them. Repeat ER visits, long hospital stays, very expensive hospital stays. But I was impressed on a recent visit to the Howard Centers for Excellence at the high quality care and impressive results that they are seeing. But they reported needing more support to train physicians in effective sickle cell care. I recently told someone from Howard that I feel like when I was introducing myself, I said, someone asked, did you go to Howard? I said, no, I didn't go to Howard. I said, but I'm a donor. And I kind of laughed and I was like, no, DC government, we are a donor. We give millions of dollars to Howard University centers of excellence, and they do provide great care, but I feel like there is a disconnect in terms of the work that they're doing. Sickle cell is one area where it's just super impressive that perhaps DC Health can help convene to sort of push out to some of the other hospitals, some of the work that is happening there.
Mhm.
Dentistry is another. I think we funded their pediatric dental clinic. We've funded the senior dental clinic, and some of the other things that are going on there. I feel like this is an area where we need more collaboration. And I'm going to say that because earlier this year, when we asked the agency about the centers of excellence and what they do, because we saw it as a budget line item, no one had a great response. And so we made some modifications in terms of how we fund them, and then we met them. We should lean in here as we are a funder.
Mhm.
We are a significant donor. And I want to make sure that they are living up to their end of the bargain of whenever this partnership relationship began. And I don't feel like we have good eyes and insight into the work that they're doing, particularly with district funds. Okay. Excuse me. Let's talk a little bit about mental health and substance abuse.
Mhm.
I know that's not completely in your wheelhouse, but it's part of your wheelhouse. Are there any changes that you envision for the role of DC Health in response to the district's opioid crisis?
I think there are several. One is in the realm of data. I think having a rounded picture of who those patients are, and really getting some data around the near misses and the reversals, not just the ones that arrive and get on our list as an overdose death. There are quite a few outside of that realm. That is job number one. I think we have the connections to do that don't necessarily exist at behavioral health. I think we have some populations that we hold that are impacted by the issue. We sometimes divide communities by what we consider their primary issue. So we have great and deep relationships with the LGBTQ plus community because we do a lot of work around HIV, which touches that community, but there is no community which doesn't have multiple issues. So how do we use our connections with these communities to bring the Department of Behavioral Health along to be able to get better penetration into that group with their services? I think the same is true for schools and youth. We should both be on the same page and be sharing kind of how we approach that. Families and youth don't really divide mental health and health all that completely from each other, rightly so. All of those things in which we are the entryway into a community, or a way for them to understand where overdose fits in the larger scope of health for the community at large. Are these the same people that we're seeing other problems from, that we can look at why they are in particular vulnerable to overdose? Maybe there are reasons that are apart from being unlucky. All of those things I think are conversations we need to have. I'm used to very closely collaborating with behavioral health as part of my internal department. Dr. Bazaran and I have met multiple times already. The stabilization site is something that I have a long history with in San Francisco, and I really want to be involved in terms of how we look at the health of those people. That group of people has a lot of disease burden. They are burdened by many chronic diseases, and I want to be sure that we're using that as an entryway to get people attached to care, and that we are helping them to manage or stabilize health issues that are impacting the substance use that they're trying to stabilize. There are other things that people may need. So we're going to be in part of those conversations. And we also have a role as a regulator in making sure that the facilities, the staff that they're getting are qualified, and that we have a workforce role in trying to make sure that the boards and groups that are helping us generate those staff are working to the top of their ability.
I'm going to go down a little rabbit hole real quickly because it was just a conversation I had with my staff yesterday of trying to determine from a regulation standpoint, who controls what. So on substance abuse treatment facilities, I understand that DBH certifies them for the substance abuse treatment piece, but DC Health does the facility inspection.
I believe that's true. And
Anybody in the back?
can either nod or shake their head.
Oh, Terry?
Okay.
No? Okay. Which part do you guys have? Obviously, you license every facility, health facility,
Yes.
regardless of what the specialty is.
Mhm.
Okay. How often do you guys do inspections of health facilities?
As needed. Once a year and then as needed.
Okay, once a year and then as needed.
But the specifics of when we inspect any particular type, I'd hate to make you think that I've memorized the entire regulatory.
No. Again, I said I'm going down a rabbit hole and I don't expect this to necessarily be from an oversight perspective, but it is something that definitely came up and I would love to follow up with you on that because I know that you guys are moving physically, location wise, and there are some specific communities in Ward 7 and 8 who could use more eyes laid on the CBOs and the facilities in their neighborhoods. And so we could follow up more about that offline. Who is going to be representing DC Health on the Opioid Abatement Advisory Commission?
I believe that is me.
Okay.
Is that the?
I mean, it says the head of DC Health or a designee. So I don't know if you were designating.
At the beginning, because I don't know entirely the realistic scope of action for all of these, I'm starting on them.
Okay.
And then we will see if there's an appropriate designee.
Great. I'll see you at the meeting. Okay. In the same area, who has ownership of My Recovery DC?
I am not sure.
That is a website.
I am not sure.
Or campaign. All right.
I mean, I can tell you what administration is likely in, but I don't know.
Okay. It hasn't been updated in like, what, a decade or so?
The digital side of communications is one that we very strongly are needing to work on.
Yes.
And I, as someone who used the website to try to learn about this job before I took it, I'm well aware of what is and isn't on.
And it's not just you guys. I say that all the time.
When
the mayor's chief of staff was head of Octo, I say all the time, the DC government websites as a whole are not very useful sources of information. It's more like we upload a PDF and hope you can find it. So we could just say that it's there. But if I am a consumer looking for information, so for instance, if I am a consumer, we were talking about this from the perspective of substance abuse. If I have a family member who is at crisis and emergency, there is not a website I can go government wise to just find what are the facilities that are available, who has beds open, and what's the numbers. We had a school who reached out because when they arrived in the morning, they found needles on the playground. Who is the entity that we call to do that cleanup and not in an 11-day time frame if they submitted a request on 311? But there is no central site. And so that's not just a responsibility for you guys, but I just feel like as we think about website redesign, how do we do a more outward facing testing usability for actually finding helpful and useful information? I keep looking to see friends. I don't have them yet, so we're going to keep going. I don't know. We might just finish with just us. In your testimony, you referred to the district's current crisis in terms of community violence. One of our goals is to view gun violence as a public health issue. And I know that was something that Dr. Lewis before you was also viewing in the same vein. What are some of your ideas of approaching this issue and how we can help every day?
Yeah, I do think there is some development and innovation needed in this area. I don't think there's a very clear evidence-based out of the box intervention. And I've talked to other state health officers, and that is essentially what everyone believes at the moment. What I will say though is that we are very well aware that health is central to most other issues. The health and well-being of the people in a family very heavily determines how well that family functions. And a family function is to know what and how your young person is encountering the community. And so the degree to which we are holding the health of adults and elders who are the caregivers of the young people who we are concerned about, we have a role. So even if we don't have a program, we have a role. And that is to use those connections to try to figure out in what way can we support people being able to do that job of oversight and parenting, despite their health issues, with their health issues taken care of. How do we connect to them as parents while talking to them about other things that have brought us into their orbit? How do our healthcare providers who are taking care of young people find ways and connect to resources better to serve them in these areas that might be able to divert them or prevent them from entering these dangerous spaces? So I do think we have a role in trying to figure out how to connect our healthcare system to better resources for them to deal with it because it's coming to them, and to connect to other partners like DBH or others who are trying to offer services to families who we may in fact have better connections with.
I think there's an entree point already in sort of the health space. We have the hospital-based violence interruption programs. Howard Center of Excellence, we've paid for their mobile unit. I'm gonna keep repeating this because we give them a lot of money. So we really should check in to make sure that they're doing all the things, but it is an opportunity, particularly in the hospital setting, to stop the cycles of violence, particularly around retaliation, because that is a lot of what we're seeing.
Yeah.
In community. Something popped off over here and then we're going to retaliate 3 days later, and it is a continuous cycle piece. But related or similar, we talked a little bit about communication. I don't know which team does it, but there is a DC Health-ish Instagram/TikTok account that is focused on youth. I remember this came up like earlier. It focused on sexual health because that's the piece that you guys have. But I feel like if you've already garnered an audience, this might be an opportunity to sort of veer into some of the other areas. So for instance, when we talk about substance abuse, around educating kids around fentanyl, right? Odorless, you can't smell it, you can't taste it, but like the dangers and complexities of just popping anything in your mouth because it looks cool. As we see a number of opioid cases rise amongst young people, it could be I guess the point is, like, we don't have to reinvent the wheel. I think you guys already have an entree point on some of these things. It's just how do we refine it to address the immediate needs of the day?
That is what I meant by what populations we hold.
Okay, great.
So if you have a connection, sexual health with youth, then we have to divide health into specialties and behaviors because that is the way we are funded. That is the way the government tries to understand it. The way it prioritizes between issues is to fund them separately. We don't have to, or at least we should try very hard not to bring that brokenness to the lives of the people that we're contacting. It is a challenge because the way in which we do reporting on how we used funds can make it complex to try to braid programs together, but it can be done. So being able to say, I'm doing this program on youth, what does anybody else have that's a concern? You're just talking about We're talking to people who use substances, while the women in that group are the same group who have congenital syphilis as the problem. So what are we doing around that? So being able to have people expect collaboration and expect that I have something that is going to happen. Everyone should already know about it because I can't possibly know all the different other intersections that are happening, because you have to focus on your thing, because that's how you're funded and that's how you're administrated. So that is why I focus on collaboration for the most part, just because you can't really approach people as whole people and whole families without doing that, because it's not natural in the system.
Okay. Speaking on collaboration, I feel like this is a big thing, collaboration, because food access is also a key social determinant of health. DC Health is the state administrative agency for several nutrition assistance programs, the special supplemental nutrition program for women, infant, and children, the commodity supplemental food program, the senior and WIC farmers market nutrition programs. And then you also fund several local funded, include Produce Plus, the Healthy Corners, Joe Food Markets, which I think are fantastic programs that I wish more people knew about. But food is not just you guys, right? Food is also like DemPed. And, recently the district invested in several grocery stores opening in low food access areas that don't accept WIC, Lidl, Aldi. We did a nice big ribbon cutting, and I'm really excited that they're there. But if I'm an individual, I can't send them there to use their benefits. Then what, I see what the point is, but we could have done something a little bit different there. How do you think DC Health should be more involved in grocery incentive efforts happening with the deputy mayor's office?
Part of the collaboration is people knowing to call you. And so having a more active role in connecting with those other agencies, there are many ways to do that. That has to be staff to staff. So picking an issue and then having staff work together on it so that we can create some relationships. But some of that is just leadership to leadership. And between COVID and the interim, it gets very hard to do anything else. So I'm hoping that I can reestablish some of those relationships so that someone thinks to call us when they have a food related issue, partly because we have so much infrastructure in that area anyway, that our role is in many ways about expertise. So, and that can be both clinical, which I know we often get, how do I do this vaccine, or what do you do about this illness? But the providing of social services that support health is our other expertise. So I'm hoping that we can build those relationships. The other thing I hope we can bring to the table is a wider view of how this health issue exists in public health as an industry and across the country. Grocery store viability in food deserts is something that has been a challenge for all cities. I don't know that anyone has found a solution, but I certainly think it's our job to go out and find if they have. But when we have something that is happening the same way in many, many different places, it's probably not a workable model. And we should be talking about what's the other thing you can do. Is that small markets? Is it farmers? What is the other thing that you can do? And I'm really happy to see some of that work happening in the staff. How do we do delivery? How do we do a single card instead of multiple cards? Whatever the methodology is to do different, we are trying to approach that. And some of that may be using the infrastructure that other parts of government have, and not necessarily having separate things as separate as they are currently. So I consider collaboration my central role is to connect us to other departments. Particularly, all of our health issues are too complicated to be just health.
Correct.
So now that we are, it's settled agreement that health is a multifactorial thing, and that grocery stores and transportation and all of those things are central to my mission, then we need to find ways to be at other tables.
Yeah. And some of it is communication too. Right. Like, I don't know, maybe whoever, and I should know this, but I don't remember from earlier this year. I don't know how many people that DC Health has working on comms, but some of the work on comms should just be uplifting the programs that other people are doing that you guys are funding. Might as well take credit for it so that folks kind of know that it's there. Earlier this year, there was Open Streets, which is a program that DC or DDOT does in collaboration with folks in Ward 5. I had my 2 kids with me and I didn't bring any snacks with them, poor on my part. But I remembered, oh, there's a Healthy Corner, or there's a store on this street that is part of the Healthy Corners program. So I told my husband, I'll just run into this corner store really quick. And he was like, what are you going to find healthy in the corner store? And I was like, oh, they have fresh produce and fruit here. And, got the girls some sliced mango and we kept it moving. But more people don't know because in some cases they are judging the outside of the store as opposed to walking in to know that that is available. But like just that type of things like, hey, do you guys know in your DC Health funds X number, blah, blah, blah. You can find it here. And I hear you in terms of coming back to the table. One of those things of coming back to the table, I would love to see DC Health back on the Vision Zero work. You all used to have, DC Health was originally on the Vision Zero steering committee, and somehow that fell off or things transitioned. But yeah, it would be nice to see you guys back on that as well.
There's absolutely internal eagerness to do that.
Okay, great. Let's talk about regulation and licensing. Let me just say too, you have an excellent team who have been holding down the fort for this longer interim period. And I've actually appreciated that because it's given me an opportunity to get to know some of the folks on your senior team who are excellent. But I get regulation and licensing is that one that everybody loves to like punch on, but they're really trying really hard to do their work. Shout out to Aisha. When should we expect the transmission of the Health Occupations Revision Act?
I am learning that legislation is a more complex issue in DC than perhaps I'm used to, slightly more layers. But I think the bulk of the work has been done. And right now we're looking at refinement and alignment, which is a part that takes other people. And so it's going to take the time it's going to take, but I expect it'll be ready anytime. But I was also told that when I got here a little while ago. So I think we just need everybody at the table to settle all issues.
Okay.
Whatever
we
they
are holding a hearing date.
That is great. I love a deadline.
This calendar year.
Yes. It's hard to regulate on old laws when you expect there to be new ones. It makes it difficult for all of the people you regulate.
Right.
So we are equally anxious
to
see it go through.
DC Health just released the long-awaited healthcare workforce task force report. It included recommendations on how to strengthen the healthcare workforce in the district. What were your key takeaways from that report?
I think one of the most important things about the way that was structured is that they looked at multiple avenues. So not a single pipeline avenue, but multiple, not just pipeline, but advancement of internal people. All of that I agree with. That is my key takeaway, number one, that we're going to have to do 15 different things, which is always hard to do. I'm always saying focus, focus, focus. But in this issue, we're going to have to take a lot of different approaches. The other key takeaway is that, and also I've heard this talking to Dr. Bazran about social workers or other folks. Sometimes we are halfway to making a pipeway or a pathway, and we just have not connected it. There are regular paths to med school. You go to this, you go to high school, you go to college, you go to med school. That pathway works for some people. And it's an equity principle that you figure out who the pathway doesn't work for and how do you build the way stations or whatever else needs to be done for the pathway to work for them. I think that's true in many of our medical careers, that people who can't take off from working because they have to take care of their families, people who have complicated lives in their early 20s and then are coming later to try to do any of these things without a school counselor to tell them what to do next. There are people who are potential in contributors to the healthcare workforce who the very rigid paths we currently have are not going to work for them. So being able to say the pathway to nurse is actually home health to CNA to LVN to nurse, so that someone can work that path instead of having to, we essentially are asking people to find their level. Like, oh, you don't want to go to school, you're a this. Oh, you're going to go to get a college degree, or you're a nurse. And we've got to stop doing that. It's not working. We have more people are Black and brown at the bottom than they are at the top or the middle. So the system we're currently using clearly has deficiencies, and we need to build other ones. I think we can do that, both around nursing, around social work. I think there are some key areas where we have pieces that we can string together. And I think that was evident in the report, that there's advancement is part of it, but I think we're missing some of the in-betweens where we just tell people this is how you do it. You go from this to this, and we have at each of those stages, how do you move forward to the next thing?
Right. What's your position on compacts as a strategy for increasing healthcare workforce in the district?
It wasn't something that, well, California doesn't do a lot of those. It's huge. But I have been learning about it since I've gotten here. I am, as you can tell, open to any solution. That's
Okay.
the new way of doing it. However, when I'm looking at the way in which at least the nursing compact was written, it is written as if you are geographically in a large state, in which the portion of the workforce that is from somewhere else is actually quite small. We are the opposite of that. The portion of the workforce who would not have their license in DC is the vast majority. So then we're in a situation where we have oversight of a large group, that we have less information, less funding for infrastructure. It doesn't quite work as written, because it's meant to be, I've got an edge city or I've got something, but everybody else just uses people who are local. That's not true here. I did even call Rhode Island to find out, how do you all do it? And it works probably because their neighbors are not in the compact. So I'm not sure what they'll do if they are. So we need to always be looking, and I'm learning it, to look at the DC lens, because DC has a lot of unique properties. And if we are going to do a solution that was created somewhere without a DC lens, because sometimes it's just District of Columbia is listed in there, but not as an entity with its own unique issues, then we're going to have to do some kind of scaffolding around it. I don't know what that is. Is it an agreement with our neighbors? Most of our licensees live in Maryland. Maybe I'm not sure what it is, but I am loath to enter something that I know doesn't fit without that scaffolding, because then I think we leave ourselves in a situation which, we're already somewhat hampered by the fact that we don't have a full board of nursing, and then we're going to change the work in a dramatic way and change the funding in a dramatic way. I don't think we have the clarity we need on how it would work.
Okay.
But I'm not open to it as an option. I just think it was written without remembering DC. And so I need them to, and I've talked to them a bit, I need them to recognize that and figure out where the flexibility is. There is not a lot. The whole point of a compact is that nobody gets to change it.
Right.
But what can we do around the edges of it as DC that plugs some of those holes, whether that's MOUs or, maybe the hospitals have a role that they don't have in other places. We need to do something though. So it's a longer conversation.
Yeah. For those who are watching who are like, why are we asking sort of a general, we have a number of pieces of legislation that have been introduced by colleagues around compacts. And the committee has been having conversations with DC Health around reciprocity agreements and other things. Forecasting what our plan is to hold a joint hearing on all the compact introductions at the same time we talk about the HORA, because they are overlapping and
Yes, they are.
related. Which is partly why I keep asking about the HORA, is because people keep asking me about the compacts. And so we're trying to get everything sort of aligned.
I will add the third issue, though, the compact, the HORA, and just our own baseline efficiency. So sometimes if you are seeing people struggle for solutions, it tells you there's a problem. And us trying to up our own efficiency or oversight, or just look internally at what is the thing that other people are making solutions for. Maybe there are things we can do internally. I think that's a legitimate question that we always have to ask whenever we are looking at an outside solution.
Okay. Sometimes it feels as though some of the quote unquote core services of DC Health that aren't necessarily the sexy things like food inspection and animal control often take a back seat to some of the more politically high profile public health issues that the agency deals with. And sometimes either aren't funding adequately or doesn't have the staffing that they necessarily need, which truly hinders the impact of the work. In the FY24 budget hearing, during the budget process, our committee added several FTEs to HRLA specifically for food inspectors after hearing that DC Health had only expected about 50% of the food establishments annually that they were supposed to do. As director, how do you plan to support these core service agencies so they don't always seem like the stepchild of the agency?
Well, my approach is that one of our main products is public trust. So people trust they can go to a restaurant, they trust their doctor is fine. And that should be in some ways quite quiet. You just go about your life. But that means having those things be consistently optimized. So whether or not we are achieving that optimization means we have to have set a goal. We have to in real time monitor whether or not we're getting to the goal. We should not be talking to you at the end of the year that we got to 50%. We should be able to project how many we're going to get to and what we need to do in terms of moving people or doing other things to make that happen. I don't know that we've done that as prospectively, but people have been really creative trying to figure out how do we risk stratify to make sure that I am still having the biggest impact, even though I don't have all the people I need. So I think the staff is really working hard on these things, and the way in which we structure how things are funded, whether they be the fees that are paid, and we've structured it to be self-sustaining in that way, but also self-limiting. We'll have to look program by program at that. I don't consider them stepchildren. I consider them core public health services. Like, that is the thing people pay us for, is to not have to worry about their restaurant and to not have to worry that their neighbor's house is going to give them rats. So all of those things that people count on for normal life are things that I think are a priority for us. That's the public's that's our obligation that the public has set up for us, even more than the other things.
I'm telegraphing for the staff who are listening to tell your bosses that the chair is on her last 3 questions. So should they want time, they should make their way to the committee hearing. Thank you, staff. Dr. Bennett, have you had an opportunity to go to the animal rescue facility on New York Avenue yet?
I have not.
Have you driven by?
Yes, several times.
What are your thoughts?
That is a complicated story at this point. I've been told the history multiple times. I do think that there is a broad commitment to do things differently,
Okay.
and that it is moving along. There are lots of people involved at this point in terms of the HRA and DGS, and there does seem to be a
So there is movement on a new facility, because I feel like we've been talking about a new facility for.
There's definitely movement. I've been on multiple
years.
meetings about where the progress is. And
Okay,
I know the
great.
mayor is looking at it very closely because I've been in a meeting with her about where the progress is. So
Okay.
we are working on it.
Okay. I'm sure we'll talk more about it during budget season.
I'm catching up on it.
Great. Let's talk a little bit about child immunization and school health. This is not an oversight hearing, but you're here. So let's check in on how some things are going. DC Health and Children's School Services rolled out a new staffing model for school nursing and health suites. How's it going?
They are nearly completely staffed. Last I heard it was nearly, so I actually don't know if we've passed nearly to fully in the last week. I believe this is the right model. I actually think it's the inevitable, more efficient model, frankly, having a full-scale nurse who has that set of skills in a school with overwhelmingly healthy children, or children who need intermittent help some of the time, is not a good use of nurse, and we have not enough of those as it is. But having a physical person there to put their eyes on a child and decide what to do next is very important, and we can train various levels of staff to do that. So using that model to stretch our nursing capacity, to have our nurses be working at the top of their scope of practice, which is what's happening across the healthcare industry. That is why you are talking to different people when you go to your health appointments. If you've got a chronic disease, there's a team of people who are working on your medications, on your management at home. So this is the same thing of trying to get more physical presence and a better use of the time of our nursing staff. So we're staffing it. It's going to have to be evaluated over time. We've really only just got there. So we'll see what the use of time for the nurse looks like, whether they are at only the school they were assigned to, whether they go to the schools in their cluster a significant amount. We'll see.
Have you had any feedback from school leadership or school communities contact you? Because I know that many people are like, oh, what are the impetus for this particular change? But one of the things that we heard directly from schools was that they did not like the temporary staffing model. They felt like it was inconsistent. They didn't know who was in the building. And so I'm just curious if anybody has reached out and said, this is horrible, or, they rarely reach out with praise, unfortunately.
There were people were imagining the future. And so I heard a lot more at the beginning before anything had been put in place.
Okay.
I have not heard since then. I check in periodically with staff, so perhaps we're about to get a lot of feedback. What I'm really asking for people to do is give the benefit of the doubt to us and our ability to model out what the acuity and severity and need for support is at our schools, and let's see how this functions. And that is not going to take a month. It's probably going to take at least the rest of the calendar year to really see how that works. Okay. But what we have now is a consistent person with medical training on the school grounds. That is not what people had before. The level of training of that person is different, but they have access to someone with a higher level of training, and they have the training to know when to call. So those things, I think, are an advantage over what we had before. Having somebody who has to relearn who everybody is, doesn't have any real relationship with kids who have chronic needs, that is not good care either. So this is a better system in terms of what my criteria are for how you care for kids who have health problems. You have somebody who can recognize sick when they see it because they know what this kid looks like on his day-to-day. They can appropriately determine when the next level of care is, and you can tell someone that for a particular child when you have the same person, and they're able to deliver the routine care of medications and other things. And we have all of that.
Right. I think one of the things that I would love to see DC Health sort of add to its performance evaluation of the grant with Children's School Services is the no-show rate. So yes, we have introduced new school associates, but what percentage of the time are those individuals not showing up? And what's our threshold for corrective action around what happens on that? And it's not something we're just seeing there per se, and we could talk offline on that front, but We're also seeing this around like when we contract out security. What happens when nobody shows up? And how often are we checking on this? And like, what are the repercussions for the person we have contracted with when they're not meeting the attendance and performance goals that our agencies have set out for them? DC Health testified in the spring that it would roll out an electronic universal health form, including an electronic asthma action plan for schools beginning this school year. Now, based on my own experience, I know that hasn't happened for DC public schools because I still had to do a nice scan of the paper form and send it to my kid's school. So what's the updated timeline for upgrading that system?
It is operational in some places. I'll have to check and see where. It is meant to be sent and completed by the provider. So you shouldn't have even had a form to scan. You just should have, nothing should have been printed out, except for take this home for your benefit. So we'll have to look into how
You guys
it's
should check in
functioning.
with Children's on that.
Okay. Any new system is going to take time to implement.
Yeah.
So we'll have, that's the point of, that's how I want us to approach innovation. You do something, you see how it works, you change it if it's not. So this system is really only started. We haven't reached the point where I would say we have clarity around what parts of it work. I mean, we have to look at even the people who are capable of it. Do we have sufficient training or technical assistance for people to do it? I don't know, but that is the expectation I have from staff to report back.
Okay. As you are thinking about data and published data or not, that's coming out of the department, one area I would love for you guys to focus on is our HIV data. So in recent years, it's taken HOSTA about 1.5 years to publish its relevant HIV data. Although providers are required to report all suspected and confirmed cases within 48 hours to the online portal. And so if providers are providing it within 48 hours, I don't understand why it's taking us so long to turn it around on you guys' side.
I know there is reporting in various spaces, including the data we give to the federal government in the CDC dashboard. So we'll have to look at where the information lives, and is it that the information is not available or that we haven't done a good job of telling people where to find it. And I honestly would have to ask that question. And I've had a conversation about our HIV data, but we need more.
Okay. Do you have any concerns or fears about taking this job? We're glad you're here, so don't get scared and go away. But, you know.
It's a big move. I had to move my house and my child. So that has been an adventure of the last 2 months. I actually don't have any concerns about the job. I think it has worked out, fate or something has worked out that the things that are being asked for by the DC Health staff and by the community from DC Health are the stuff that I do. So I was listening to people testify and they were echoing words I was about to say in my testimony. I do think we should be the convener. I do think we need to publish data all the time. All of those things are the things that I care about, that I enjoy seeing done, and that I have some experience doing. So my history in the job and my temperament seem to fit just about right. It was a big move. And so I'm still trying to make that regular life happen. But I got a few more boxes.
Well, welcome to the East Coast and East Coast time.
We'll see what happens when it gets cold. I'm not hardy. I'm from San Diego.
Oh, yeah. It might not, though. I don't know. Climate change,
Yeah, I
Although they said that next week's highs are supposed to be this week's lows. So you might get a sweater.
Yeah.
Just sweater weather to plan.
I got my San Francisco layering skills.
Okay, great. To just sort of follow up on something that the public witnesses said, would you be willing to meet with the Long-Term Care Coalition?
We've already corresponded about getting a meeting together.
Okay.
So I absolutely intend to. My meet and greet list is something of a behemoth. So yeah, I've I've been meeting and greeting with all I have. So if I haven't gotten to anybody, it is not for lack of effort. And I've not been sitting at home. I've done more than one social event in a day, which for my introverted self is a lot to ask. But I have met a lot of people. It really hasn't been as much an order of priority as an order of who had an opening when. So lots of important groups I haven't met with because it just hasn't worked out yet. But all of our healthcare organizations, whether they be the voluntary associations like the Medical Society or the Hospital Association, all of those groups are really key partners. I was telling we brought all the medical boards to all the health licensing boards together. They are the biggest workforce policy body for health. You know, whatever we figure out is either going to go through them or come out of them. That is true for lots of these organizations. Being able to aggregate the problems is an important resource for us. Otherwise, we're going to waste our time on stuff that's not the effective thing to do. So I deeply need them, and we will make it happen.
Great. Give me just 1 minute. For all the staff who are listening, well, it's like last call. All right. We're done. I want to congratulate you again, Dr. Bennett, on being selected as the mayor's nominee to serve as the director of DC Health. It is a large job. DC Health has a lot of administrations, a lot of parts, but I find that they have an excellent staff, great bones in terms of the work that is being done there, and certainly the passion for the staff who are there. I want to thank you for your time and for being very thoughtful in your responses to the committee's questions. I also want to thank all the public witnesses who testified today and raised important issues regarding DC Health and Dr. Bennett's new leadership. As I end it seems like all of my health committee hearing these days, it's going to be 2 PSAs. First, to any of the healthcare workforce out there who are licensed in the district and want to serve on any of our boards, 19 professional licensing boards, we need you. You can go to the Mayor's Office of Talent and Appointments and submit your information to express your interest in serving and joining one of those boards. The second, in terms of DC Health being active and out in the community, this Saturday, October 7th, is Open Streets on Georgia Avenue, and really excited to have worked with DC Health to have a DC Health presence out on the route from 9 to 3, where there are no cars, just people scooting, biking, walking, I don't know, hopping on a pogo stick. We could probably see it all. But DC Health will be out giving out COVID rapid tests at 2 street intersections, which I used to remember. I think one is like between Kenyon and Irving. And then there's another one not far.
I hope we're not asking me a
I don't know. I'm looking behind you.
Oh, good.
Or next to me. Okay, there are 2. We'll see you there. We plan to hold a markup to consider and vote on Dr. Bennett's nomination on Tuesday, October 10th, where we will also consider and vote on 2 other pieces of legislation before the committee. Bill 25-0290, the Access to Emergency Albuterol and Glucagon Amendment Act of 2023, and Bill 25-244, the Prescription Drug Monitoring Program Amendment Act of 2023. I believe both of these were in the DC Health wheelhouse. Was prescription drugs? That was them. Yeah, okay, so both of them. So thank you in advance. Well, not thank you in advance, but your staff has been really excellent in working to refine those pieces of legislation. Yes, the second location is between Quincy Street and Randolph Street Northwest, again, from 9 to 3. Open Streets is a rain or shine situation. And my understanding is that's supposed to be showers in the morning, but sunshine later in the day. So I'll be there with my 2 little bikers. But this concludes today's roundtable. The time is 12:49 p.m. and this roundtable is adjourned. Thank you so much.
Thank you.